Welcome everyone to this third CHE Policy Forum. My name is Mark Scolfer, Head of Department at CHE. This is CHE's 40th year of research in the field of health economics, trying to develop and deliver good high quality research with a policy impact, and that policy impact is the focus of this series of forums. And an important strand of CHE's research over the last 40 years has been in the area of policy support for decision makers in low and middle income countries. And that's been particularly prominent over about the last 10 years, where we've had some strong research in Africa and other parts of the world, and that's what we're going to be focusing on today. And this research has absolutely been grounded in enduring partnerships with local academics in low middle income countries and policymakers in health and other relevant departments. So the idea with these forums is that we present research, but we also invite two external discussants to comment on that research. And today, Paul Revill, who's a professor based at CHE, is going to talk about building a policy-focused global health economics research programme. So he's going to talk for about 40 minutes. And then we're grateful for two external discussants joining us. Katharina Hauck from Imperial College London is here with us, who will be the first discussant. And then our second, Jo Keatinge, who's based at the Foreign, Commonwealth and Development Office in London. Sadly can't be with us in person, but she'll be joining us, we hope, by Zoom. So Paul talks for 40 minutes, Katharina and Jo for about 10 minutes, and there'll then be plenty of time for questions, both from the floor and also from those joining us online as well today. For those of us in the room, there are handouts at the back that you're very welcome to pick up. And I think that's all the preliminaries I need to mention. So I'll hand over to Paul for his presentation.
Thank you, Mark, and thank you for everyone for coming today. Also, special thanks to people who've joined online. I know sometimes it's difficult and you can feel a bit distant from things when you join online, so appreciate all of you who are online as well. So, again, I listened to a radio programme last week, and the interviewer asked the interviewee, do you think of your job, as a career, or as a mission? And the implication was that the more an individual could think of their work as a mission and derive purpose from it, the more they'd commit all their abilities fully to that job, and it's more likely that they derive value themselves and maybe make an impact on the outside world as well. And it made me think on this occasion, the 40th anniversary of the Centre of Health Economics, how appreciative we should be of the endowment that's been given to us in the field of health economics from many people who've worked for CHE for the last four decades. And it's great to see a number of people in this room who've really been at the forefront of developing the health economics field and have given so many of us now the opportunity to derive and undertake meaningful work, but also have developed and sharpened the tools which are applied across the world and in many ways have impact and benefit for population health, here in the UK and in countries across the world. Now, much of the work of the Centre for Health Economics through the last 4 decades has been focused on developments in methods and applications in the UK and settings like the UK, particularly in high-income countries. And with a few very notable exceptions, we haven't done lots of work which has been more global in relevance, particularly honed at addressing some of the health challenges in lower and middle income countries especially. And as Mark outlined in his introduction, that's changed somewhat over the last 10 years, where we have been able to develop various programmes and we're working with academics and policymakers, actually in almost all world regions now. So I'm going to tell a bit of a story about our work which has been focused on East and Southern Africa, in Malawi, in Uganda especially, but also in other countries in East and Southern Africa, and try to derive some thoughts and lessons from that which might be insightful for us also in our work in the UK, how we continue to advance our field of health economics and apply the tools which are available to us in a range of different settings. So, I don't need to point this thing. There we go. Oh, too early. So this photograph was taken in 2016. It was in October 2016 in the Crowne Plaza hotel in London. And we were about to go into an interview for which the outcome of that interview would determine whether we, as a centre with our collaborators in the UK, Malawi, Uganda and Africa, would be awarded a grant of £6 million for the programme which subsequently became the Thanzi programme to build a health economics research programme focused on healthcare policy making in the African context. And on the left-hand side, here is Liz Stewart from the ODI. I'm sure you recognise two of us, and middle myself and Mark Stulfer. There's also Dr. Benson Chilima, who is the director of the Public Health Institute of Malawi, so a very senior policymaker from Malawi, and Professor Tim Hallett from Imperial College London. And we went into interview to present the work and the thoughts of what already was starting to be a broader collaboration through which many people had input. And preparing for this interview, no stone was left unturned. It makes me laugh looking at the size of these humongous folders which we had, which were full of possible questions and responses to questions, and we felt we were ready for the next 45 minutes, which would determine, with a chance of around 2 to 3 to 1, whether we'd be funded. And the interview was to begin by Professor Stulfer, Mark here presenting 5 slides to make our pitch in 10 minutes. Now Mark, what happened there? Mark ran out of time on slide 2.
I don't remember that. Just typical that.
But I remember Dr. Chilima made a sterling performance and highlighted to the panel how this project, which we were developing, was needed in Malawi, in the East African region, and I'm here now, so we're clearly funded for this project. And here we were 4 months later with Mark in Malawi, and I believe Mark appeared on Malawi national news this evening, and he also had the chance to finish the 5 slides when we were in Malawi. And we had a gathering of the full team. And we were at the start of this journey. We've been given this award of £6 million to create something which we hoped would enable us to use the tools of health economics and further advance them to derive meaning from our work and have beneficial impact on population health. But almost at the same time as receiving this award, the weight of it bore on us. We were given £6 million to do research in Malawi, which is one of the very lowest income countries in the world. And we're economists, and we know that budgets and resources have value, can be used in a whole range of alternative purposes. And we'd also done work which indicated the healthcare system in Malawi was able to generate population health at very low cost. And we believe the health system in Malawi was able to generate a healthy life year, so 1 year of additional health for somebody who otherwise wouldn't experience that, for around £100, less than £100. So to justify this award came on us that really we were going to have to do something which at least had the potential of improving health. So the amount of 60,000 healthy life years from the Malawi population is huge, huge burden. A few £1,000s for your life saved. So at the same time being so excited about this opportunity we had, we also had to grapple with how we could use this opportunity and turn it into something positive and meaningful, which was likely, or at least had the potential, to make a meaningful difference on population health. And although we had plans from the proposal, we really hadn't thought this through in sufficient depth and detail. We had to go to the drawing board to think about how we could use this opportunity to create something which could feasibly add value. So what we did was thought about how research could potentially add value which would translate into health improvement for the population of Malawi, Uganda and the region. And I think I'm of the view that all research can only ultimately be beneficial and add value to society through affecting decisions of some form. Some research, basic science research, may affect decisions which are made years, decades down the line, maybe by private individuals or private firms. But research which generates knowledge, I think, can only be beneficial to society if it works through affecting decision making which has consequence for society. And for those of us working within health, being concerned particularly with public funded healthcare, collectively funded healthcare, the decision making which I think is most meaningful is decision making of ministries of health and national authorities which are responsible for the organisation and funding of healthcare within any country. So in Malawi, that was the Ministry of Health in Malawi. In Uganda, it was the Ministry of Health in Uganda. So our task as researchers was to generate research which could have a beneficial effect on decision making with a large impact on population health. Now, how could we do that? We couldn't do that by being sat in York or the University of Malawi or Makerere University alone. We needed to engage with those people who were making decisions about health policies and healthcare resource allocation. And the more we thought about it, we start to realise that to have the best opportunity, the best chance to affect decision making, we needed to combine research with meaningful research to policy interaction and engagement, and also to enhance understanding, capacity strengthening, capacity building of researchers like ourselves, but also of policymakers to use, to think about, to critique, and ultimately determine whether the research was suitable for advancing policy formulation. So we built something of an infrastructure, an architecture, led by knowledge in Malawi and Uganda in the region, which formed three strands of activity: research, research to policy engagement, and capability building. And what we started to discover is that these three strands of the activity reinforce one another. By enhancing capability building and understanding of policymakers, we could work with them to better understand the limits of our own research and how advancements in research and methods could better improve policy. By doing safe in the research, that enables us to have better relationships with policymakers. We also understood what the needs were for future capability building. So these three strands of activity, research, research to policy and capability building, interacted, but they were all centred on improving decision making over the use of healthcare resources, with the ultimate goal being population health improvement and health equity. And I think when you combine these three things, sometimes, it's never easy, but sometimes some magic can happen where you can get to a position where you feel like there's advancements and things are moving forward, with the ultimate goal of population health improvement being what we are concerned with in the end. So I'm going to talk you through these three areas. I'll spend a little bit of time talking about capability building and then policy partnership, and then I'll spend the second half of the talk focusing on research and how our own research was advanced through our policy engagement and partnership. So let me begin with capability building. So if we're concerned with decision making, public health decision making, and ministries of health, and I've already said that we also want to work across that research to policy interface, we need to think about capability building, both of researchers, producers of research, and policymakers, the users of research. And in particular, we want to support interactions across that interface, and actually even careers which straddle those two worlds to some degree. So we started to design a set of activities, which were multi-pronged, but was concerned with supporting that career pathway and research to policy interface. And this involved strengthening capability of individuals, but also of institutions. Now, individual capability building can be supported through short courses, through studying on master's programs, on PhD, and through collaborative research itself, capability on the job. And we did all of that. We continue as a programme to do these activities, but we also try to combine this with institutional capability building. That includes our master's programme here in York, and our colleagues in Africa are inputting into this, but also includes us inputting into master's programmes in Malawi and Uganda. And those two countries actually have MScs in health economics beginning this coming academic years. So it's curricular development, it's guest lecturing, it's examining each of those courses, and this is moving forward. And that in itself can be the spur for research and growing interest in research and policy circles itself. Another principle that we've tried to follow is that as far as possible, and I've got to say the University of York management has been fantastic in enabling this, we've made our materials free or online for public use. And this website, which I encourage you to have a look at, globalhealtheconomics.org, is a repository of all the training material, many of the training materials which we've developed. And I want to point to one thing here in particular which has been supported by the university. This is an advert for the first cohort of 14 studentships which were made available to Ministry of Health officials and those working in public universities in Africa, and they're now following a 3-year distance learning programme in health economics here at York. And we're combining this we're trying to strengthen training programmes across institutions. We had, with Helen here, we had the first peer learning and mentorship call last week, actually last Friday. And here we have students from, let me name the countries, from Gambia, from Ghana, from Pakistan, from Bangladesh, from Malawi, Eswatini, Uganda, and Zimbabwe joining this call. So the reach of York training and the demand and appreciation for this is increasing, but actually we feel that we're just at the beginning. What about policy partnership? So I've talked about the interface of research and policy. And these are represented in most settings by two institutions. On the one hand, in most countries you have a Ministry of Health or a Department of Health, as we call it here in the UK. And then on the research academic side, you have universities. And too often, these two camps are somewhat separated. People who are working in universities don't routinely engage with policy officials working in ministries of health. Those in ministries of health often feel the university are quite separate from the day-to-day work. But actually, particularly if we're talking about public universities, government offices and universities share a common public ethos, and they're concerned with well-being of the population. There is common ground across which the two can come together. And in some ways, they need one another. We as researchers need the outlet for our research, and policymakers need the guidance and evidence of which to form their research. So based upon an idea which emerged from within Malawi, actually within the Ministry of Health in Malawi, through the Thanzi programme, we've supported the establishment of a new unit in Malawi, which is called the Health Economics and Policy Unit, HEPU. Now the HEPU is co-owned between the Ministry of Health and the university. It's housed within the university, where it actually involves secondments of staff from both institutions to the Health Economics Unit. And more than that, it's created the structures through which researchers and policymakers routinely engage. And as an example, they convened important meetings during COVID in terms of how Malawi would respond to the situation. So there's an opportunity to create structures between these based upon local needs as they're identified. Colleagues in Uganda, on a visit to Malawi, saw the HEPU model and actually thought this would be a good idea to have something similar in Uganda. And in Uganda they created, according to the same principles, but something called the Health Economics and Policy Programme, HEP, called Uganda. But it sits between Makerere University and the Ministry of Health, and it's a bridge across research to policy. More than this, other countries have seen this model and have written reports outlining a desire for how this model can be applied in a whole range of settings. Rodrigo here, my colleague, is going to El Salvador in a couple of weeks to have a discussion with the Ministry of Health in El Salvador, who have expressed interest in the same model. And we believe if it's in the interest of both parties, as also in the UK with the health policy programmes, there's maybe an opportunity for us as academics and as independent parties to support the coming together of research and policy communities. So in Africa, as well as Uganda and Malawi, Eswatini, Swaziland, is about to embark on this model, and there's also been lots of interest in other countries. I won't name them, but a number of policymakers have visited Malawi to see the HEPU. And this shows another opportunity. The UK, Malawi, Uganda, ultimately we share similar challenges. And one of the beneficial things which has advanced health economics in East Africa, and I hope my colleague Edward Keatinge is online, is to support regional learning across ministries of health in neighbouring countries. Edward works for an organisation called the East Central and Southern African Health Community, and every year he's convened a meeting of the directors of planning and the budget holders for the 9 countries within his community to learn from one another. And it's through these fora that recognition and appreciation of ways of working through which health economics evidence can have a greater bearing on policy has advanced. Have I done with this then? So here we go. You can see this is a meeting of the HEPU in Malawi, and down here is a regional meeting of the ECSA Health Economics Community of Practice with members from 9 member states here. So let's move on to research. Just give me a minute, I'll get some water. I've outlined how our belief is that research can contribute to enhanced decision making over limited healthcare resources, but to do this it should be combined with earnest research to policy engagement and capacity strengthening. I think most of us in this room at least are researchers, so let's talk about the features of research which can be most beneficial to informing decision making over limited resources. Now, because of the structure which has been created within Thanzi, the model is absolutely not that any researcher sits in their office, comes up with an idea and seeks to apply it. But research comes from discussions and interactions with policymakers. And policymakers can tell us the limits of our research in areas which warrant further consideration and advancement. And in the early days of the Thanzi programme, we would sit and we would present the possible contributions which we could make. And from our policy colleagues, there was a recognition, appreciation of these. Sometimes they would come back, often they would come back and say, you haven't grasped everything. We work in a country where the healthcare system is under-resourced, sometimes weak, sometimes dysfunctional. What can you tell us about how to strengthen the system as a whole, rather than which interventions we should be delivering? And I've got to say, at that stage, we didn't have the answers. We still don't have the answers, but it's become an evolving area of research which has been motivated by the policy need. So in the Thanzi programme, we've taken an interdisciplinary approach to research. The questions are health economic in nature, so health economics is most prominent, but we also have important strands of research on epidemiological modelling and political science, public finance, which come together seeking to improve the evidence base for decision making over resource allocation. There's been a whole wealth of research, and I encourage you to look at the website to explore that more fully, but I'm going to focus in this talk now on our research to guide investment in health system strengthening. Now, a lot of us are health economists here, but I'm aware not everyone is, and maybe also some colleagues online are not health economists. So let me just give you a quick introduction and understanding of our discipline. So health economics deals with, broadly, the allocation of limited healthcare resources. And you could characterise the purpose of our discipline as being to answer this question: how can health of populations be maximally improved? But we have to contend with the fact that not everything that offers benefits to patients can feasibly be funded, because in all countries in the world, even the richest countries in the world, the systems are subject to budget constraints and other constraints existing within the healthcare system. So the challenge for us, the central equation of health economics, if you like, is to determine how budgets and resources can be utilised across a whole number of needs, let's say non-communicable disease care, maternal and child health, public health, also healthcare system strengthening itself, and recognising that whenever anything is funded, so if a new intervention, let's say for maternal and child health, is funded, this is likely to be associated with health gain, but also incurs budgetary and resource consequences. And because budgets are constrained, this means if we introduce or expand one type of intervention, there are other forms of healthcare, other interventions which could have otherwise been funded, which can no longer be, because the resources are committed to whatever intervention, maternal and child health intervention, is ahead of us. So you bring something in, something else needs to go out. We need to grapple with opportunity costs in the language of economics. So the central equation of health economics is to assess whether the gain from new interventions is likely to be greater or less than the health foregone from what's displaced. If it's greater, we can justifiably say something's cost effective. If it's less, we can't. So this underpins a lot of the type of work that we undertake. And to give just one example, this is a study that the collaborators involved in the Thanzi programme through the HIV Modelling Consortium conducted to guide the World Health Organization, who were updating their global guidance on how patients with HIV receiving treatment should be monitored. And they wanted to know whether they should recommend countries monitor patients on the basis of clinical symptoms or lower cost tests, CD4 tests, or whether they should scale up a more advanced diagnostic, viral load monitoring, which was seen as more sensitive, had clinical benefits, but was more costly. So the results of this paper said, let's imagine this viral load monitoring is introduced. We believe it can be cost effective, but only if the cost of the diagnostic is offset by reducing the frequency with which patients see a provider. So you have one diagnostic which is introduced, but you have a cost offset through reduced clinic engagement. And we concluded that in most cases we'd expect it would cost just over $300 per healthy life year gained, and this would be judged as being cost effective in most settings. And this is how most economic evaluation, much health economic analysis is conducted. However, there's a gap from the challenge which faces ministries of health, and actually the conventional approach to economic evaluation in this sense is that there's one overall healthcare budget with the sole aim to generate health of the population, whereas as our policy colleagues have expressed to us in the real world, and particularly in low and middle income countries, but actually probably here in the NHS as well, healthcare systems are subject to budget silos. So some diseases are better funded than others, some healthcare inputs are better funded than others. There are limits to real resources, so there might be a limited healthcare workforce, or the spacing of facilities might not provide access to everyone who needs healthcare when they need it. And there are system weaknesses leading to poor implementation. So we tried to, the group which was involved in this work also continued the analysis and went back, and we started to try to see if we could specify the implications of this work in a way which would have more meaning in the variety of contexts in which viral load monitoring would be delivered. And on the right here, we have a hospital in Malawi, Zomba Central Hospital, which I purposely haven't taken any photographs of patients, but it's bursting at the seams. It's a very crowded hospital, and the healthcare workers there are overstretched, and they struggle to meet all of the patients who come to them. Now, in such a setting, if there's a reduction in the use of one type of resource, in particular reduced frequency of clinic visits, this means the healthcare workers can spend their time treating other forms of patients, and actually the health improvement might even be larger than we'd expect on average. There's real value to that limited resource of a healthcare worker in this setting. And we ran the analyses trying to reflect this, and we concluded actually the real cost for generating a healthy life year was much less in a setting such as this, because the benefits of releasing that constrained resource are much higher than in other settings. However, this compares and contrasts to a setting such as this. Now, this is a health facility in rural Uganda, and there are 2 nurses working at this facility, and they are there basically to manage, to a large degree, maternal health cases which present themselves with some degree of unpredictability. They also provide HIV services, but this isn't a clinic which is overrun with patients. So if you introduce an expensive diagnostic machine and you expect that can be compensated through reduced use of healthcare worker time, reduced clinic visits, that doesn't really translate to a setting like this. And if you rerun the analyses trying to reflect that reduced clinic engagement doesn't mean more health is produced elsewhere, the same assessment in a diagnostic, you incur the cost, you don't incur the benefit of reduced capacity. The cost effectiveness of the diagnostic then is less attractive. Now, we don't do this standardly in health economics, but we should, to generate meaning in an array of contexts. And this is just an example, but the point I'm trying to get at is health systems matter. health systems matter, and we need to contend with the implications of weak, imperfect healthcare systems within our field much more than we typically do. Now, the World Health Organization says all healthcare systems require a number of building blocks: service delivery, health workforce, information systems, financing, leadership, to function effectively. So I've showed in the last example that some types of interventions be maybe more or less cost effective if we consider the implications of the healthcare system. However, our field hasn't told us how we should go about investing in the system itself. And this is now what we need to turn to. In recent years, there has been an advancement in the theoretical literature which has provided greater insight into how the benefits of healthcare system strengthening can be assessed. And Katharina, with Professor Pete Smith here, have made real strides, particularly in advancing the theoretical literature, and have outlined some approaches which can be used to generate evidence. However, as of 2020, in a systematic review by Susan Cleary, there were no empirical applications which guided how healthcare systems could be strengthened beyond single diseases or single interventions within low and middle income countries, and I think the same might be true anywhere in the world. So we've set as our task to try to advance methods and think how evidence can be generated to guide investment in healthcare systems, which differ, of course, across contexts. And we've advanced two approaches. Firstly, we've tried to advance an approach which we believe is replicable in a range of settings using the types of data which is available in most countries. And this is number one here, expanding optimised packages of care, thinking about what would be an optimised package of care and what's the implication of system weaknesses in limiting delivery of this. And secondly, we as a collaboration have advanced an approach which we think will shift the frontier of our discipline, basically. And this is grounded in assessment of what healthcare systems are currently doing. Let me go through these. Firstly, expanding optimised packages of care. And this came from a direct request by the Ministry of Health in Uganda, who wanted to know from their budget, from their annual budget, how should they prioritise this across a whole range of interventions to ensure they have the greatest gains from their annual spending on drugs and commodities. They had just shy of $300 million per year to spend on drugs and commodities, which represented about half the health sector's budget. But more than that, healthcare worker density was very low. Less than 2 medical doctors per 10,000 population, 12 nursing staff, and very, very few pharmaceutical staff. So one approach which we developed, if you're interested, is a linear constrained optimization, mathematical program, which took all of the interventions which would be considered in Uganda and effectively put them through a funnel. What could be afforded within the drugs and commodities budget? What could be delivered within the capacity of the health workforce? And could we account for any other system limitations when choosing this set of interventions? And out of that, a number of interventions were identified which seemed to offer greatest gains and could be delivered within feasible means in Uganda. And these are the results here. I won't spend long on these. But just to say, the usual approach for cost effectiveness analysis would be in this column here. We'd select, in Uganda's case, 81 interventions, have a large impact on health, but we would far exceed the drugs budget and the capacity of the health workforce to deliver these interventions. So through adopting a mathematical programme, we factored in these constraints to identify a package which could be delivered within feasible means. Now, this is somewhat beneficial in choosing the interventions, but what we believe is even more beneficial in this approach is that it can guide us on where the greatest gains would come from through relaxing constraints in the healthcare system. And in Uganda's case, I present here how many healthy life years would be generated by committing $1,000 to either a drug and commodities budget here or investing in the health workforce. And we found that the greatest needs in Uganda's context were for nursing staff, pharmaceutical staff and nutritional staff on the basis of the evidence that we had before us. We repeated this analysis for Malawi, and actually looking at the package of care in Malawi and the constraints which exist in the Malawian healthcare system, it appeared that it was higher skilled healthcare workers, doctors, which were the main constraint in delivering the most cost-effective forms of interventions in Malawi. So results differ by context, and we need to work together with experts in health systems within any field and try to identify what the greatest gains are through investments in the healthcare system. So that's 5 minutes. So this has taken us so far, and it starts to give us evidence which we can use to ask the question more than anything. We're not going, as researchers in Malawi or the UK, going anywhere saying, do this. We're saying our analysis indicates this might be an issue. Does this ring true to you? And actually, policymakers and experts in the systems have said, kind of, yes, it does, which is reassuring. But where we believe this field is going is that we have an opportunity to model these types of considerations in much more granular detail than has ever been done in the past. And for the last 5 years, a fantastic team from Imperial College, London, from UCL, from York, and the University of Malawi has been modelling Malawi's entire healthcare system in granular detail. All healthcare workers, all facilities, access of individuals experiencing different types of conditions to facilities, supply chains for drugs and equipment, pretty much everything you can think of in Malawi's healthcare system. And there are 3 components to this model. Firstly is modelling demographics and epidemiology, so incidence of disease and how this is likely to change through time. We'll see a growing burden of non-communicable diseases away from infectious diseases as populations age. The second component is modelling the system, as I've described, and the third is health-seeking behaviour of individuals who seek to access the system and will either receive the care they seek or will not, and there'll be a consequence, of course, either way. So we're excited for this model. It's starting to be used now in Malawi, and in future we believe it will be used in other countries. We think there's a role also here in the NHS, the UK, for such an approach. I just want to give you one insight into its application and potential use. So I indicated that one of the things which was assessed was the implications of breakdowns in supply chains. And I don't think there's been any literature, at least I'm aware of, which has looked at the consequences and what can be done on a value for money basis of addressing supply chain weaknesses in healthcare systems. Because we have this micro-simulation model of Malawi's healthcare system, we've utilised the data. Colleague Sakshi Mohan, who might be online, has taken the lead in utilising this data, and which shows which drugs and commodities are available in which healthcare facilities in Malawi when. So when there's a breakdown in supply chain and the drug and commodity is not there, that appears through the data, and the consequences of that can be modelled. We've started to look at correlations between breakdowns in supply chains and what might be causing that as a hypothesis generation exercise for future implementation science research. But what we're finding already is that if we take the supply chain as it currently functions and then make it work perfectly, we'd expect the health generated from Malawi's healthcare system to be 20% greater than it actually is. And if you could translate that into effectiveness of a clinical intervention, it's equivalent to eliminating a major disease in Malawi. I'm not seeing the MRC or an IHR or others really commissioning research which is getting into details of how supply chains, as just one example of a healthcare input, can be strengthened and addressed for population health. So So it's been a long journey for all of us involved in this collaboration across a number of countries. Sometimes it has felt it's been a barren landscape and been challenges along the way. But I hope to, if I speak for collaborators as well, I think by combining research and being guided by the needs of policymakers and working within an environment where we're working across these three domains of capability building, policy interaction and research, there's treasure to be found for those of us even if we're only concerned with research. I started the talk by talking about, trying to think about how can we as researchers, research community, possibly think about, justify the commitment of funding to us. We need to show benefit from this. Now, we don't have the privilege as health economists or as analysts to know that what we're doing is definitely beneficial. Doctors and nurses have that privilege. They treat a patient in front of them and we can see if that patient improves. However, our discipline has been, is and will into the future offer great benefits in terms of population health, even if we can't always directly attribute our efforts onto that. Just to give a sense of what's happened in Malawi. So this is a quote from Professor Atul Gawande, who leads Global Health for USAID. He's an acclaimed academic himself. He was in Malawi a few months ago, and he says this: he arrived in Malawi and got a close-up look at the primary healthcare system, and in the past decade, the country's made significant strides focused on improving delivery of essential health services, and life expectancies jumped from 55 to 65 years. All credit to our close colleagues at the Ministry of Health in Malawi who fought their battles on prioritisation. It's been a privilege to work with them. He notes that these gains have been generated through under 5 maternal death reductions, and that occurred even given a very fragile economy and a severe healthcare worker shortage. So we don't have the privilege of knowing for sure ever that our work is beneficial. But when you see gains in population health, and when that's attributed to prioritisation, which is the business of health economics, that feels good and is advantageous. So thank you.
So our first discussant, Katharina Hauck. So Katharina she's a former member of CHE, so she's particularly welcome, and a long-term collaborator, but also a great person to provide some review and commentary on what was presented. Katharina is a Professor of Health Economics at Imperial College, London, and Deputy Director of the Jameel Institute there. So, Katharina, thank you.
Thank you so much, and thank you for inviting me here. It's a particular pleasure for me and honor to be here and celebrate the anniversary of CHE, of which I, of course, have many warm memories doing my PhD here and my master's, and following your research over the years. Particular honor to talk about the Policy Applied program, and I thought, how do I spend the 10 minutes that I have in discussing such an amazing program? And I think I will give you a very personal account of what are, for myself, the main features of the Thanzi program. So I pick out really 3 aspects of your work, which is, I think, the clear quantitative approach to health system design that, for me, stands out to other approaches in health systems research, acknowledging the complex realities of constraints that go beyond just a single budget constraint, but are the many different complexities in the health system. Then the second, I think, major advance that the Thanzi program achieved is the integration of economic and epidemiological research, and mainly dynamic transmission modeling. The impact of interventions on the untreated, that the modeling, the multidisciplinary modeling that you do, that can be achieved. Of course, it greatly complicates the analysis and requires collaboration with mathematical modelers. And then the third one, I think, that became clear during Paul's presentation as well, the co-production of research decolonialization of research that goes beyond capacity building approaches. And let me put that on a timeline against the increase in life expectancy in Malawi. And I just took out a few papers and a few contributions that have appeared over the decades. They are not the most important contributions in health economics by far. They are not even very highly cited. But for me, when I read them years after they were published, they frustrated me slightly, because I thought we haven't made progress on that at all. But I highlight them now here because I think that the Thanzi program has made significant progress on these. So the first paper that impressed me was Ann Mills, who called for quantitative assessment of health system design in the year 1983. So it was a grainy copy that I read. HIV was not mentioned among the list of diseases, and she went actually into detail about that it's not only a singular view on whether it's a vertical or horizontal health system, but that it's a very differentiated analysis, how we can incorporate vertical health programs that are often carrying a high benefit and cost effectiveness and are a good idea to do when the health system are constrained. But she said there's really no approach of how we can evaluate these programs if we have not only one constraint but many constraints that frustrate our efforts in combining this. And of course, these are the discussions around determining the cost effectiveness of integration, the efficiency gains of economies of scope, or as Pete Smith always said, we can't realize the benefits of economies of scope in joint delivery if we have no means of relaxing key constraints that go beyond the budget constraints, but that are important inputs in the production process of health. Or in other words, if we don't have slack in the system, we can't really achieve this effective integration. So I think that was the first contribution where I think Thanzi really has an answer for us after such a long time. The second focus of Ann Mills' work was that she said we don't really have any means of assessing the cost effectiveness of primary health care, as she called it at the time, and investment into health system delivery platforms that have benefits across many different diseases and programs. Of course, Thanzi has made a very practical, very pragmatic and quantitative approach to that. And the third one is the integration of economic and epidemiological modeling that Ann Mills was frustrated about, that this hasn't happened enough. Now, of course, 10 years later, the AIDS, or as it was called at the time, the AIDS epidemic struck, and I think as far as I know, the very first paper by Philipson appeared, that of an economist, of a welfare economist, who incorporated an infectious disease model in his work, and he kind of coined the term economic epidemiology. And of course, his the focus of his work was not cost effectiveness assessment of health programs, but it was more like, if we integrate behavioral responses, what do we learn about the optimal control and elimination of infectious diseases, something that I know you and your colleagues are interested and what do we learn if individuals react to the prevalence of a disease around them, and if a decrease in prevalence is a decrease in the price of risky behavior, what does that mean for the control of programs? What does it mean for projections of epidemiological models on elimination? A third, I think for me, seminal event, not only because it was my first boss, but also because she, of course, talked a lot about global health, and she emphasized how public health, as we know it, is dead, she said. I remember that and said, well, global health really requires health issues that transcend national borders, and they require global approaches to governance and to cooperation, both on action and on research as well. Now, of course, at that time, which was around 2004, less than 1% of all research originated from institutions in low and middle income countries. So we can see in 2008, DFID, I think then for the first time, giving out a report on capacity building, as they called in their times, in developing countries, and giving out guidance and advice how to increase the capability of conducting and disseminating and using research in constrained settings. Now, we all know that this kind of approach in a way doesn't go far enough, so I think another seminal event coinciding, I think, with the birth of the Thanzi program in 2016 was the World Humanitarian Summit, where I think this is an agreement between global funders and international organizations trying to attempt a true decolonized overseas development assistance and humanitarian assistance program with a commitment to localized action, localized leadership, true participation, and then funding that acknowledges that with fair funding for overheads, for localized leadership in the countries where research and action is taking place. And also, of course, we see that this grand bargain very much in the spirit of the Thanzi program. Of course, at the same time, we see this amazing increase in life expectancy, very much correlation, of course, with the introduction of the Thanzi program. So let me thank you to Che for 40 years of amazing advances for human health here and in countries around the world, and also for giving us so many amazing tools and solutions for our work. Thank you.
Thank you very much, Katharina. So I'm hoping now our second discussant is able to join us through the wonders of Zoom.
Yep, I'm here.
Joe, welcome. Thank you very much. So can I introduce Joe Keatinge from FCDO, the Foreign Commonwealth and Development Office. Joe's been working in this field for many years, and she's going to reflect on the extent to which research projects like Thanzi provide guidance and perhaps hold to account organisations like FCDO. Thank you, Joe. Over to you.
So thanks, and I really am sorry I'm not with you today. I'm afraid I've been doing a lot of travelling and it just didn't work. But Paul, a great, fantastic presentation, and I had a whole list of things to say, but actually a lot of the points you've already covered in terms of the process that needs to change. And so I suppose what I'll just highlight and bring up again is, I don't know why you're worried. We do need this kind of economic analysis, and it is very much valued. And what is really fantastic is, I remember meeting Pete, I don't know if you remember, up in Glasgow, and saying, when are we going to start doing some work on integration and health system strengthening rather than vertical programs? So my first point is really that what you've done in Malawi needs to continue in terms of helping other governments with that kind of analysis. And I think we need to move away from kind of siloed program thinking, where whether it's HIV and TB or malaria, and move to more sophisticated system kind of analysis to look at the real trade-offs that will need to be made. So not meddling around the margins, but really looking at what this fundamentally means, I think, for system reforms. So I think you've given great examples of what that can look like. I think my second point is we are facing major fiscal constraints, whether that is, with our ODA amounts or whether that's the governments themselves. And this sort of analysis is even more important than before. And it's really going to be critical to look at the whole and not individual parts. So I think taking that system approach to this is really, really welcomed. And there is that tension because we often get funding for one analysis versus another. And I think collectively, together, we need to challenge that and say, there are broader decision-making processes that need to happen with a limited fiscal space that many countries are dealing with. And I think the third and final point is I just love the way that you've embraced working with local institutions. And I think the regional institutions are becoming much more and more important. And that is the focus of where we will be moving and shifting our financing, is to really not set the exam questions in the UK, but actually set them as part of a regional ask. And what is it that we need to, where can we support using, the expertise that's in this room that you're in, using the networks that we've got, using all that really difficult complexity in terms of modeling and applying that, but listening to actually what governments want. And I think it's really important that I just signpost the new FCDO white paper, where patient development is much more at the forefront under the steer and championship of Minister Mitchell in particular, that we need to hear that voice from who we collaborate with. But having been part of writing the FCDO Health Systems paper, we really need to not tokenize, we need to listen to countries in terms of what they want from us. And it may not be this and it may not be that. And that is where we need to be guided by in terms of prioritization and decision making. So all I can do is applaud this shift to more systems thinking. You need to sort of convince the siloed disease folks, as I do every day, that there is this new way of kind of methodology. People don't need to rethink it. There are proven ways of doing it, and we need to make sure that we're listening to our government counterparts to actually continue to finesse what's already been done and take on more of what they want us to research, provide evidence for, and ultimately kind of align in terms of investments with their priorities. So I'm going to leave it there, but thank you so much. A really rich conversation. Thanks.
Okay, so opportunity now for questions. Those online, please put your questions in the chat. We don't seem to have any yet, so please rush ahead with that. Those in the room, please put put your hand up if you're interested in asking a question. Nick, just mention who you are, perhaps.
Nick Bosenkamp, the last survivor of the first staff at Che. And also at that time we and I would mention the name of Mark Wheeler particularly, who spent a lot of his career in Africa. We did a pioneering project with Botswana on their improving their staffing and health manpower, where I was involved, and Roy Carr-Hill and one or two others. So it's great to hear these developments in Malawi. I'd like to know more about what the gain in life expectancy came from. Was it a reduction in infant mortality, or was it a reduction in adult mortality? I would guess it was probably infant mortality. Is that so? Yeah. But the challenge now for the next, how are you going to use this capability? And one way is to try to use, and it's not a disease silo, because reducing early deaths from heart disease and respiratory disease requires a clinic program rather than any special centres in capital cities. How are we going to use this capability to improve lower mortality and improve workability for adults in the population? That's a tremendous economic gain if we can do that. I pointed that out again and again to people involved with planning in India. They're missing a hell of a lot from the of economic gain from the very low life expectancy of adults. So how are you going to meet the new challenge, as it were, beyond the infant mortality one?
We'll have a go at answering that, Paul.
Yeah, sure. Thank you. Thanks for the question. And I haven't actually seen that paper by Mark Wheeler on Botswana and Manpower. I'm going to search for that after this meeting. The increase in life expectancy initially were driven through tackling the HIV epidemic most largely, but that's been combined and more recently enhanced through reduced maternal mortality and making gains with against childhood mortality. But the big shift, not in recent years, but say from kind of 15 to 5 years ago, so it's been particularly through addressing HIV. And looking forward, using kind of this capacity and what the big challenges kind of on the horizon in many systems. Well, the story, if we look at East Africa particularly, the story for the last 20 years and more has been the burden of infectious diseases, and particularly the big three of HIV, TB and malaria. But as these start to become controlled and as populations age due to addressing HIV epidemics, there are growing epidemics of non-communicable diseases, which bring their own challenges. So there's some talk now of the dual epidemics of continuing challenges with infectious diseases, but really worryingly growing NCD concerns, for which there are not at the moment the international funding systems to help address them, not least because of the issues that Joe highlighted with really constrained fiscal space from the UK and countries. So how that's managed in future is going to be an ongoing challenge, but increased efficiencies, integration of services, delivering services where people can access them is likely to be part of it, but we really need to get granular detail in terms of what that can be.
Katharina, Joe, anything to add to that?
Yeah, I think the day of singular diseases is coming to an end, and you're right, Paul. I think that we need to, that there are changing burdens and there are changing needs. Climate and health is another big one, and I really think there is, and that was actually what I was going to put in my bullets, this focus on efficiencies and risks to the health system are really important to take forward. And what is that going to mean in terms of delivery models, in terms of the next stages of what we need to look at? And I think we're really rubbish at kind of starting to gather the evidence of the challenges we know. So we've got the NCD stuff now. Do we have what climate's going to do? We need to think ahead always, and because the story from the economics is so important. And I would also say that we need to tell the tale in a narrative that ministries of finance are going to listen to. So not just ministries of health. So, what is the cost benefit in terms of, we need to change the narrative that health is an investment, not a cost. And so I think all of our analysis needs to start shifting with the real big changes that we're facing at the moment. Thank
you. A question at the back?
Oh, hi. Pippa Anderson from Cardiff and Swansea Universities. I came today in person to enjoy being here, but also because I really thought I'd learned something from this talk to take back to Wales, because we've been doing a lot of work over the past decade looking more at not whole systems but whole pathways and whole services, which has been incredibly rewarding. So, and I have learned many things already. But what I want to ask you is, what have you learned that you'd want to bring back here?
You want to reflect upon that and come back?
Yeah. Can I on Joe's point about providing a narrative to ministries of finance? I think there's we have one. Look at this. As our colleague Priscilla Candula, would you possibly mind saying something about your work? I think it's exactly geared towards speaking to ministries of finance.
Thanks, Paul. So we did some work focused on 5 sub-Saharan African countries: Eswatini, Malawi, Mauritius, Zambia, and Zimbabwe. So this was trying to look at the structural shocks that would affect spending in health, and then trying to see the relationship between health outcomes, where we're looking at infant mortality as a proxy for health outcome, and how that is linked to the macroeconomy. So we're trying to find a fiscal multiplier in line with what was being discussed of having this narrative about health being an investment rather than a cost, because the findings did show that there's that rivalry in terms of financing when it comes to health versus other sectors, which are seen to be more tangible, like maybe infrastructure. So a lot of politicians would rather invest in would rather see the investments going into those areas, especially if they're looking at like a 5-year term. And so they tend to neglect sectors such as health, but we can clearly see the impact in the long run that health financing will have, even though it has a very short run, a very small multiplier in the short run. So this was aimed to inform some policy dialogue that was happening between ministries of finance, ministries of health, and some other key stakeholders, to try to have that dialogue in terms of how we can increase spending that goes towards health, so that there can be that achievement towards the universal health coverage.
Thanks, Priscilla. I just got a quick question. Actually, got a few now. Just one actually. Online. So this is from Dr. Emmanuel Ankra Adami. Have I pronounced that correctly? He's highlighting the community participation was later integrated into the WHO health systems building blocks, and asked whether community participation can be integrated into the health systems model that you've been describing. Reflect upon that. I just want to get a few more questions in. Rodrigo.
Thank you. Rodrigo Moreno Serra from the Center for Health Economics at EU. First of all, just want to thank Paul for the presentation and Katharina and Joe for insightful comments there. Really a lot of things to think about. My question is about, I think many of us in the room are convinced about the value of investing in health system strengthening, and we take that focus in a lot of the research that we do. Many people here in the room, I know they do. I guess my question is, it is arguably the case that it's harder to show the benefits of investing in health system strengthening than it is, for example, of investing in vertical programs like an immunization campaign. So you get to, with an immunization campaign, to the Minister of Finance or decision makers or budget holders, it's easier to show them what the money has achieved than what you've achieved by just relaxing certain constraints within the health systems, and then you try to make the case that this is actually going to have a bigger impact than an immunization campaign, let's say. So I wonder whether, given the fact that we have here a representative from FCDO as well, whether you, the panel, thinks that the fact that it's harder to show evidence about the benefits of that is one of the constraints for a bigger support of health system strengthening investments, both in research but also actually implementing interventions that will strengthen the health system within institutions like FCDO, but also multilateral institutions. So is that a big hurdle for actually the investment in those areas of health system strengthening to increase at the rate that we would like to, and actually shift the narrative towards moving away a little bit from the whole focus on vertical programs? Thank you.
Just hold that one, and we'll just get a few questions and then perhaps address them at once. Karen.
Thanks. I'm Karen Rowlinson. I'm Dean of the Faculty of Social Sciences, and I just want to say first of all congratulations to Che on 40 years. It's a fantastic department within the faculty and broader university. Faculty has supported much of the work on global health and invested in some of the work here, and I'm really pleased to be here and see and find out more about it. So yeah, well done, and it's great work and great to see Che going from strength to strength. I'm not a health economist, I'm not an economist, I'm not a health expert at all. My background in terms of academic work is in social policy and also particularly in poverty and inequality in the UK primarily. And while it's great to see this holistic approach in terms of health expenditure, there used to be a department in the UK called the Department of Health and Social Security, looking at these holistically from sort of health and welfare. So my kind of question, again, this is just, you've done a huge amount, and I just want to extend it even further and think, if we were to spend on social protection, what kind of health gains might we have compared to spending on drugs, spending on health systems, and could you have that holistic kind of government, so the silos of departments, and there are lots of silos within departments of expenditure, but could we look holistically about spending to improve health, and what would that look like?
Thanks. So we've had questions from Dr. Dharma online, from Rodrigo, and from Karen. Anything further you want to say in response to Pippa? Who wants to go first?
You go ahead, Paul.
We had Katharina and I were speaking just before this workshop around systemic risks, Joe, that you've highlighted, and really, we agree with you very much that our field is really not grappling with the significance of systemic risks to health sector and how they can be addressed to increase health system resilience as much as we should be. And it feels somewhat that we're acting based upon what's happened rather than what could happen in future. So there's been a huge increase in pandemic risk, of course, but actually healthcare systems are subject to multi-layered risks, natural disasters due to climate change, economic risks, which have highlighted pandemic, and maybe political risks or conflict as well. And it does feel like it's great. Katharina, you might want to talk about your work on pandemic preparedness, but as a field, it's certainly an area we can be doing more on. In terms of, so thanks so much for the question, what have we learnt for the UK? And I guess I think one of the conclusions we've drawn is that healthcare systems in all countries in the world, whether very high income, whether low income, wherever they're geographically located, are actually dealing with challenges which are more similar than you'd think. And usually it's a matter of emphasis, what is the primary challenge to be addressed in some way. So for instance, in the UK, over the last 20 years, we've struggled with rising spend on drugs and commodities, and we've created systems such as NICE to try to address. Now, that's still a problem in Africa, in East Africa, but not to such a degree. However, one area, coming back to the central point of this talk, investing in the system is as required in the NHS as it is in any country, really. But because we've got by, and because the system as a whole somehow has been functioning until recent years where maybe it's falling apart a little bit too much, it hasn't been a focus of research, but I anticipate that it will be in the coming years. The research need to address systems issues has been more prominent in Africa, but it's not missing from the UK. So thank you to the question from Dr. Emmanuel Adame. Dr. Adame, until very recently, was the Director of Planning for the Ministry of Health in Ghana, and he visited Malawi and Uganda to explore what lessons could be learned for Ghana from the Thanzi programme. And that's a great question. Thank you, Dr. Adame, about the implications of community participation, integration of community approaches into the systems model. Again, you've identified an area which we are currently seeking to address and hope to do more work upon. So I presented our work which showed the constraints to formal healthcare delivery. And there are at least two ways we can think of where those constraints in terms of formal healthcare worker capacity can be somewhat overcome. One is through enhancing community approaches to take some tasks away from the formal health sector and locate them more in communities. And another is to look at potential role for, it makes me uncomfortable to say this even, but the private sector, and particularly private pharmacies, as when there's routine healthcare use, maybe some of that, particularly with advances in computing systems, maybe we can make greater use of the private sector to deliver public healthcare, not through private providers, but through private pharmacies, particularly than has been the case in the past. So to answer your question, Dr. Adame, it's something we're beginning to work on now, and we think there's a lot of promise to enhance community healthcare systems, which will further help us on the path to fuller healthcare provision by easing burdens in the formal healthcare sector. And Karen, that's a great question. The best person to answer your question, I'm not sure if he's willing to here or not, but the person who's just been doing work on this is Carl, Professor Claxton. I'm not sure if you want to answer here, Carl. Or?
Yeah, I think you're absolutely right. I think,
hold on.
Could you pass it down? Yeah, I think you're absolutely right. You know, there's been a silo of thinking about, is this a health intervention? If we're health economists, we look at health interventions, but that's not the case at all. We're interested in what social value do we get by devoting public funds in particular ways, and that's the direction we've been taking over actually recent years now. So we've, as well as estimating the health effects of NHS expenditure, which are considerable, we get a lot for our money, we're also looking at what we get from adult social care expenditure, and we get many things from that, not just an improvement in quality of life for recipients, but also quite a significant impact on carers and their mental health. But in actual fact, as just reviewed the first draft of a paper that's going to journal, we've also estimated the effect that has on measures of productivity in the wider economy, and it's considerable. So adult social care pays for itself times over in the short and the long run. But there's also important interactions between these public sectors. So what we find is that if you spend money on adult social care, you actually reduce mortality considerably. That mortality reduction is not from the recipients of social care. is operating entirely through the impact that adult social care has on the composition of NHS spend. So I think you're absolutely right. I think, my agenda is not to see things in terms of health, but to see things in terms of the social benefit of public expenditure, to do two things. One is to show that actually we get an awful lot from public expenditure, and you need to know that if we're going to properly inform the debate about appropriate levels of public expenditure, but also to hold to account those that want to sell things to the NHS or social care. If you want to sell it, well, let's make sure you're doing more benefit than we can currently get with existing technologies.
Thanks, Carl. Katharina, I just want to give you an opportunity to just particularly something on system preparedness for pandemics, I think, Paul, you suggested. But anything you want to cover that we've been discussing over the last 10 minutes?
Yeah, so not so much to add, but I think what's really interesting to see that the progress actually is fragile, even on the communicable diseases, the three big ones that we thought we had under control. We saw how the COVID pandemic and the resources that it took to combat that, how that set us back on many indicators. On HIV, malaria and TB, we can see that very clearly. And then I think the climate and health agenda is really something that is worrying, and a risk that is very hard to quantify, both in terms of what risk are there of additional spillover effects as the atmosphere warms. There will be more exchange between the species and much more risk of diseases spilling over. And we see, for example, the resurgence of dengue that at the moment many countries are grappling with, and where the vaccine is complicated and requires quite careful modeling. And I think there is an agenda for us to look at the co-benefits in terms of health of climate action, which some people are doing very interesting work in. Then the multi-morbidity that I think we have talked about, and the problems that health systems face of combating both, and research now showing, for example, in the case of COVID, how actually obesity was a major contributor to COVID mortality, potentially as important as age. And then, with respect to preparing the system for the next pandemic, that we have to consider as a real possibility in our lifetime still to happen, or the work that we need to do on estimating the return on investment to getting vaccines distributed faster. So what are the returns really of advanced investments into vaccine, our R&D, manufacturing, procurement, and distribution capabilities, and then the question of stockpiling. How much should we stockpile? Very concrete questions that we are being asked, and questions which are very difficult to answer. So I think all of that creates challenges for health systems that make for a rich research agenda for the.
Thank you. One last question. Pete.
So, can I come in?
Please.
Sorry, because I think there was a question to me also. I think was it Rodrigo? Yes. And it was about how difficult it is to turn the ship. I think on systems versus siloed. And that is why my hair is grey. It has been incredibly difficult to turn the ship. But I actually do think if you look at FCDO's new white paper, if you look at the direction of travel, health systems has finally landed. And I do think there is a real shift away from silos, discussions about diseases. And there's a new initiative called the Futures for the Global Health Initiatives, which is also looking at what that's going to, what are these big institutions going to look like in 20 years' time. whilst, you know, HIV is as you know, or less common than diabetes. So I really feel that there's a real shift, and I've been working in this field for such a long time now that I can feel it. I think one of the key things that you should all be aware of is that we're also trying to start to get everybody to measure a set number of health system performance metrics that will also help us to then analyse some of the cost effectiveness of different interventions. Because at the moment, there isn't a common definition of what health system strengthening is and which interventions and what does that mean. And so, in fact, I'm having a meeting in a couple of weeks with WHO to lead that piece, and ITAD also did a piece that is worth looking up, that looks at evaluating health systems and performance, that might feed into some of the work and the thinking, because people, you know, we're all saying, yeah, we all have a different definition. And then I just want to really briefly touch on the social protection issue. It's really interesting because I think there's growing momentum, if you look at the SDGs and the international space, that financial protection is probably going in, you know, a really bad direction. And it's linked to also, and COVID's highlighted the social protection issues, along with what needs to go alongside financial protection for accessing health services. So I think it's one to watch out for in the international space. WHO have just put it as a core outcome in their general programme of work moving forward. And I think that you guys with the health economics background are going to be really, I can see this agenda growing. You know, what does that mean? I was at a meeting in Montreal last week with all these, you're all, I'm not an economist. I get intimidated by you all, but it was really exciting to see that this is on the agenda. So I think there's lots more that we can do and look at in that space as well.
Thank you very much. Thank you, Joe. So I think we're out of time. I think it's been a really, really interesting session. Thanks for everybody for your contributions, and in particular to our two discussants, to Joe and Katharina, and of course to Paul. So thank you very much.